questions, stop and we'll go back through it. Sometimes I speak a little too fast, and what I do say may not be totally correct because it comes out too fast for me before my brain thinks about it, and so stop me. Usually if I've figured it out, I will stop and say, no, that was wrong. Here's what I really need. Okay? Much of this will be pathophysiology. So if you went through the slides, I won't ask you to show your hands in front of Dr. Latassi, but if you went through the slides, you'll see that a lot of this is pathophysiology. Pathophysiology, pathophysiology. It's what is your bread and butter as practitioners. Regardless of whether you see peds patients, grandmas, work in the emergency department, but especially in primary care. Okay. So we'll start with the pituitary gland, mainly because it really controls every other gland in your body. I'm not quite sure how it got designed that way, but I'm not sure I could come up with a better way. But it certainly reminds you that some illnesses and injuries can have a significant toll on an individual's long-term health. So if you have a pituitary infarct, you have a head injury from, what's it called? What's Dr. Coleman? The cage fighting. He doesn't do it, he's the physician who takes care of those who decide to do it. So, you know, cage fighting, falling off your bike on the middle of the Broadway extension or something. So those sorts of injuries can have a profound effect on a variety of organ systems because of the fact it controls so many glands. And usually when the pituitary acts up, then it's because it's not so much something that it in and of itself is bad, it just doesn't do what it's supposed to tell the other glands to do what they're supposed to do. So what you end up with is not so much a pituitary disorder, but you end up with an end organ abnormality of thyroids and adrenals because the pituitary is not sending out those trophic hormones to stimulate or decrease the stimulation of end organs. So when these trophic hormones are elevated, you end up with an increase in the glandular function. And thus, you may find that your patient has signs and symptoms of hyperthyroidism, for example, but don't pat yourself on the back because you're not done yet. That may in fact be the diagnosis, but it is your job to then figure out, is this the thyroid itself that's overactive and causing hyperthyroidism, or is it the pituitary that's causing that gland to overact? So getting to the diagnosis isn't necessarily the, ta-da, you're done. You need to be sure that you don't need to go one step further in your evaluation. So you all have had gross anatomy, right? And so you know where the pituitary sits, and you know what can happen when it gets too big. That it encroaches upon that area where the optic tracts cross, called the optic chiasm. And so that growth may be symmetric and you get bilateral visual symptoms, or it may be growing more in one direction than the other, so you may get a unilateral visual symptoms. But most of the time, patients will have, when the pituitary gets big enough to do that, the patient usually will have headaches as well. But frequently, it's the visual changes that are the symptoms occurring that prompt a patient to come see you about, you know, look in one direction and I see an overlay. I see two images, but when I sweep back across the rest of my visual field, it's fine. And that may be because of increase in the size of the pituitary gland. And so again, the first primary, you know what this means, primary versus secondary failure, okay? So that's my shorthand. It should be pretty common to you. So as the pituitary grows and as you have symptoms, you need to decide, is this a primary pituitary problem? Maybe it's a secondary cause of hypothyroidism rather than a primary cause of thyroidism in the gland. You can see that the posterior pituitary gives you the release of two kinds of hormones. You know what vasopressin does? You know what oxytocin does? Okay? And so then if you just remember that those two come from the posterior pituitary, then everything else comes from the anterior. And those are the sex organ stimulants, the FSH and LH, as well as your adrenals and growth hormone and thyroid stimulating hormone, and then prolactin as well. And that actually, I would say, I've probably had 2 or 3 prolactinomas in the course of my practice, where one was a man who started developing some discharge, and the other were women who were no longer of childbearing age. Okay, so here is just take the top of your skull off, pull the brain out, look down at the bottom. You can see that pink area. That's where the pituitary sits, in that region. This X-ray is all we used to have before someone decided to invent a CT scan, even better, an MRI scan. And so when a patient had visual changes, headaches, and hyperthyroidism, one of the things you would do would be to get a lateral skull X-ray. Very easy to do, low radiation, cheap, and you would look, and the radiologist would look for that area where the number 4 sets to see if that is a normal appearing area for the pituitary to set into. Or, as we see in a minute, when it grows, what happens to that area. So what's it called? What's where the pituitary sits? You got it, okay. And so, who knows? I Googled Sella turcica a few years ago, trying to figure out slides, and I came up with this movie poster. And I've never seen the movie, so I have no idea how good or bad it is, or I think it's in English, but I can't imagine, other than it's someone who must be a paraplegic or can't get out of their chair, so they're saddled in this wheelchair or something, but rather creative. And so again, this is a normal lateral skull, and you can see that 1, 2, 3, 4 area corresponds with the 4 in this shot, okay? So then, here is a normal versus an abnormal. As that pituitary grows, it puts pressure on bone, and pressure on bone causes resorption of the bone. And this is an example of, you can see that the sella on the left is much thicker, more calcium in it, and then as opposed to this one, whereas this tumor is actually growing, it's probably a posterior pituitary tumor and growing, putting pressure on the posterior aspect in this area between 2 and 3 and causing that to be resorbed. And so that's all we used to have, and they'd say, oh, you got a pituitary tumor, and good luck, sort of thing. I don't know if this is going to work. This is new to me this year. So this is a normal MRI that we're going to see. Did you guys click on this link? Did you run through it?
It works.
It works? Okay. Because right here is the pituitary. And this big white, bright white spot, that's part of the cella. And so, maybe this will work. Where are my guinea pigs? Okay, so, we can go up here. And so this is, you're looking at this area right here. This is all part of the cella there. This is a normal MRI. This is pituitary gland there. Here's part of the cella coming around, and still a normal pituitary. And you see the infundibulum, which is that stalk right there. And then the slices are thick enough that you see some of the infundibulum, but it's so thick that it doesn't catch the rest of it. That's why it seems to disappear, just being only in one slice. And then again, here is towards the edge of it as well, and we're out of it now. Okay? I don't know if that was helpful or not, but here we go. Okay, so that this was part of it down, clear down here, and so I think that actually that video portion is a better shot than this one here. So let's go through some pathophysiology. So the pituitary can fail. So the pituitary can fail for a variety of reasons. And we try to figure out why. It can be from a viral infection, meningitis. You all, I hope, had your meningococcal vaccines to get into school here. But any sort of meningitis, what we would generally call aseptic meningitis, meaning it's a viral cause and not a bacterial cause, that can cause fever and an infarct of the pituitary. Then women, there's a specific syndrome in which they have postpartum or intrapartum hemorrhage to the point that their pressures drop low enough, long enough, that it infarcts the pituitary. If you dissected out the pituitary, you can see how tiny the infundibulum is and how small those vessels must be. So it doesn't take much pressure change to decrease the blood flow to the pituitary, and thus, if that happens for a long enough period of time, then you end up with an infarcted pituitary. And then other things that can happen that I've never seen are sarcoid, the infiltrative processes of lymphomas, and things like sarcoid or some of the rheumatologic diseases. But the Sheehan syndrome could affect only a portion of the pituitary. You might think that if you have Sheehan's that it all dies, or if you have a pituitary infarct from fever, that the whole thing would infarct, but that may not be true. You may get loss of posterior pituitary hormone function, but the anterior may survive, or any combination of that. So this is an MRI which shows, it's somewhat analogous to that lateral film, plain film, that had loss of the cella that you can see here, because all MRIs come with arrows to help me. You can see this tends to be the normal contour, and this irregular, it's just half again as big as it should be. And it's pushing and growing out, and that pressure is enough to make the bone resorb and give you evidence that the pituitary has a tumor, probably, as opposed to an infiltration. So, that's the pituitary. We can image it we can assume it's normal if we have a normal lateral skull. We do not ultrasound pituitaries. You can CT if that's all your facility has and you think you need it at that point in time. Or better is an MRI imaging. And we don't do PET scans unless you think there's some, unless you've had an abnormal MRI, or you think you have metastatic disease primarily from some cancer like breast cancer or bone cancer of some sort. So pituitary can quit because you've had an injury to it from head trauma, can quit because you've had fever or an infection, or can quit because there's infiltration of an exogenous source, if you will, a lymphoma, sarcoid, that puts pressure. As that deposition occurs, it crowds out and puts pressure on the cells that actually produce the trophic hormones and shuts down the production of trophic hormones from the pituitary. Okay, ready to go on? All right, so thyroid. Thyroid function probably is, the thyroid gland is probably the gland you will evaluate the most in your life as a professional. And one of your faculty who had an important part in my education is Dr. Bonetta. And I remember him saying, always feel someone's neck. You can't feel an abnormal thyroid if you haven't felt hundreds of normals. So when you're doing whatever you're doing, if it's reasonable, put your hands around somebody's neck in the course of your exam, feel for your thyroid. Even if you're feeling for adenopathy because of a sore throat, take the time to practice feeling of the thyroid. So, you know, it's kind of symmetrical, it looks like a butterfly, and it only works when what tells it to work? TSH, okay? TSH is the most common endocrine test I order, probably twice a week, because someone has hypothyroidism or because someone has symptoms of low or high thyroid disease. And so it's a great screening test, and it's, as I said, the most common test I order regarding thyroid function. And then, on occasion, I may do a T3 or a T4. I never do a reverse T3. That you're really looking, when you think someone has hyperthyroidism or hypo as well, you want to know if they have active, you want to know what their T3 level is. Is it really high? And then your job is to figure, if it is, your job is to figure out why it's high. And so I usually do a TSH to screen. I may do a TSH, T3, and T4 if my TSH is elevated or really low. I do a follow-up test to make sure it's still really elevated or really low with a T3 and a T4 together. So the T3 is the one that gives you your energy and or turns you into a sloth if it's not if it's below normal. The T4 is primarily made as a storage, as your storage or your reserve, and your body has the ability to take that T4 and push it into reverse T3 for further storage, or move it out into actual T3 if you're in an event in which your thyroid hormone levels need to increase, such as burns, hospitalizations, surgical, having your gallbladder out, or appendix, something like that, where your metabolic rate requires more thyroid hormone to get you healthy again. So, you know what the thyroid looks like from dissection, touching it, holding it, and so it really looks like that when we start to image it. And sometimes you don't have to image somebody to know what they have, and I think the next picture kind of tells you that. But tell me your answer to this question. You all heard the term goiter. Okay, you know what a goiter means? It doesn't mean something going on with your knee or your bowel. It specifically relates to thyroid. So a goiter is an abnormal enlargement of the gland, and so which of the conditions can cause a thyroid to get bigger? We generally think of hyperthyroidism. Okay. So the answer is actually all of them. So they can all get big for different reasons and get as big as this woman's. This is not her thyroid that you see in the other side of the screen. But you can, this was a common size long before we had what simple thing done? Iodine added to our salt. And so if you do volunteer work, you go on missions, you may go to countries where salt is harvested from areas where iodine is not indigenous, or it's not part of that culture's salt. And so you may see goiters. But we don't see them really anymore in the United States as a result of an iodine deficiency. I have seen women who surprise me when I would be in cultures where women wore wraps or shawls, and not until I was passing them did I could see that this was hiding a goiter. And I thought, I've actually seen one. Oh my gosh, I've seen this woman in this picture. Nowadays, we never see anybody like this unless they've been an immigrant, I suppose. And you can tell from this photograph that this probably is in an era before World War II. Could have been after World War II, but probably not in recent times, although there are areas of the United States in which housing is still at this level. But probably, this is clearly part of a goiter, and there's probably this is probably thyroid tissue as well. This could be a normal lobe over here, but the isthmus seems a little bit large as well on this specimen. Okay. So now we'll talk about hyperthyroidism, increased function of the thyroid gland. And you guys should be able to recite this in your sleep, what the symptoms are. And so you probably could give the patient's history. Once they say, I'm sweating all the time, I'm hot when others are cold, you can probably tell them exactly what they want to tell you, because you're well versed in the symptoms. But what else have you learned about that sounds similar to this? What other hormone or glandular abnormality gives people cardiac awareness? You know what that means? Palpitations, feel like your heart's being too fast, going to jump out of your throat. Weight loss, maybe thinning hair, heat intolerance, sweating. That thing that I've searched for and found one time, the FIOs. So just because it sounds like a horse doesn't mean it can't be a zebra sometimes. Right? So physically, early on in the course of this disease, the thyroid may be tender, but it may not be diffusely enlarged, but it might be. So that's why you need to know what normal thyroids feel like. You may be able to palpate, or your nurse or MA pay attention to the vital signs. They're there for a reason. Their pulse is 112. It doesn't have to be 140. Look in their old chart. Look in the flow sheet. What is their pulse usually running? 82, 74. Well, now today, if it's 110, that may be one of the physical manifestations of this disease process. So pay attention to the vital signs. You may be able to rub your hands. That's not what happened to me. Okay, I don't need comments on that. So they may have, if you grab your patient's hair, you feel of it. Does it feel dry? Does it feel brittle? Does it pluck out easy? Does you end up with 5 strands in your hand when you test the integrity of their hair? Physically, you may feel a nodule, or you may feel a big thyroid. You may find tachycardia, if their skin may feel wet and clammy. Then who do you know, a public figure, recently deceased, had exophthalmos at a point in time in her public life? Barbara Bush. So if you look at some of her older pictures, she had she didn't necessarily have the traditional exophthalmos like, Marty Feldman, where his eyes are 2 feet ahead of him. But there would be photos that you may find where she looks like her eyes are really wide open. And that's really where she's had some of this infiltrative process that started to try and push her globes a little bit forward. And this is in part because the intrinsic muscles of the eye get bulkier. They've bulked up, and so they're crowding the globe a little forward, and you get some proliferation of connective tissue and deposition of some of the hyaluronic acid derivatives in a retrobulbar process that, if left alone, if left untreated, the globes would actually push forward and pop out. And so it's important to try and prevent that from happening, because it's hard to make the globes go back in. Once the muscles may get a little bit smaller, but some of this proteinaceous material will not go away, and so there still may be a little bit of exophthalmos present in patients who've been successfully treated. Okay? So, any questions about hypothyroidism? You should know this cold. Hypothyroidism is just the opposite. People have no energy, they've had weight gain, their hair, again, comes out. It may be coarser, their skin may feel a little more coarse. Hard to know in some men, might be more easily recognizable in women, especially if these are patients that have been in your practice for 10 or 20 years, where you know what their skin or hair feels like because you provided their care for quite some time. Cold intolerance, so that makes sense. The weight gain makes sense. Fatigue and or lethargy makes sense. Paresthesias, you just have to remember, I don't have a good explanation why that happens. And then sexual dysfunction, primarily in men with erectile dysfunction, as opposed to women. You may be able to pull their hair out more easily than if they didn't have thyroid disease. You may feel that their skin just feels a little strange to you compared to what it may have been the prior few years. There may be a voice change, and so in men it's maybe not so noticeable, but it could be in your patients who may sing in the choir at church or in high school choir, or just people say, you must be going through puberty, your voice is changing. Facial edema is another finding. I've found it hard to really identify. I usually think facial edema associated with what? Renal failure, proteinuria, and patients get swelling in the face that tends to go away as you're up during the day and the gravity takes it down. And then physical findings. One other physical finding. You know what DTR means?
Deep tendon.
Deep tendon reflex, exactly. So if you set them on a table and the easiest is generally for you guys is our patellars, and it just may not return as quickly. It may be a little slower than you're expecting. And so it's hard to describe, but you kind of know it when you see it, or if you think, well, that's strange. Maybe that's what you perceive, is that, well, they have a good response out, but it just seems to take a long time to go back. That's what we're talking about. So, whether you think the thyroid's overactive or underactive, or you think you feel a lump or a bump, then the first image that we do is an ultrasound. Why would that be the case? So it's cheap, okay? So you got to think about spending my tax dollars providing Medicare health insurance to Dr. Latassi, okay? Whenever she reaches that age, right? So it's cheap. Is it harmful? No, not harmful. Not that anyone's been able to get a court settlement out of anyway. And it's been around a very, very, very long time. And it's easy. It's readily available. If you have an x-ray department in your hospital, there's going to be an ultrasound service. Now, it won't necessarily be in the clinic that you're in, but any emergency department may have access to it. You're not going to do it in the emergency department, but you may want to end up referring them to an ultrasound as part of their referral back to their PCP. So it's cheap, it's easy, it's quick, and it doesn't hurt. If you've ever had an MRI or a CT, they don't hurt. It's hard to lay still for the time and that may be required for those images, and they're expensive. So we usually do an ultrasound. If you feel a bump, so when you evaluate my performance today, you are not to evaluate my graphic skills. All right? So, you feel this man's neck for whatever reason, and you think you feel a bump. So you try again, and you give him a little more time, give him a drink of water, and you feel again. So now you say you feel something on the right lobe. Okay. So, what is it that you're feeling when you feel that bump? Do you know at that point in time?
No.
No, you don't know. So an ultrasound will tell you. Why? What will it show you?
If it's fluid filled or not?
Oh, exactly. So an ultrasound really gives you black, white, and shades of gray. So you know that a thyroid's supposed to be solid in color, or solid, but if your ultrasound shows a black hole here, then that's probably a what?
Cyst.
That's probably a cyst, right. So then, if the other bump you feel blacks out, so then that's a what?
A nodule?
A nodule, right, okay? You gotta get the language right, so that when you talk to me on the telephone about my patient, you can use the right term and I know exactly what you're talking about. So it can be a solid nodule or a cystic bump, okay? And so the ultrasound does this very well. However, just like driving an automobile, it's user dependent. And so a good ultrasound tech is a blessing because they will figure out how to get you the best views of the structure of the thing you're looking for. And if it's a small nodule, they'll find it. Someone who's not as skilled may just say, we don't see anything. Or they provide images for the radiologist who says, normal study. Okay? It can also look through the thyroid and look at some posterior structures, such as the parathyroids that we'll talk about in a minute. All right. So do you guys understand these slides, these next couple of slides with scans? All right. So you do the ultrasound, and I say, yep, there's a bump there. Yes?
Do you think you could go back and just walk us through this ultrasound picture?
Oh, yeah. Okay.
There is a pointer where the chalk is. Should be a long stick. That's it.
My century of technology. All right. I'll try not to blind you with my bald spot. So here you go. Butterfly, right? Okay. You can see the isthmus. One lobe seems to be bigger than the other, but remember, you only get to see views based on the position of the probe. So if the neck is turned a little, intentionally or unintentionally, it may look asymmetric when it really is symmetric. And that's where your ultrasound tech is worth their weight in gold, because they will send lots of images to the radiologist that will give them the ability to say symmetric thyroid or enlargement of the right lobe of the thyroid. So this is a normal thyroid gland. I don't know what that is. And that is all black. You could argue maybe there is something going on down here or over here. But this is my representation of what a normal ultrasound looks like. Okay. So, you felt the bump, you did the ultrasound. What lab are you going to do? Yeah, so I do a TSH, and if it's hyperthyroid symptoms, I'd probably do a T3, but I'd at least do a TSH for sure. And so I say, well, Mr. Jones, you got a bump, and it shows it on the ultrasound, so you need to have another study done. Okay. And he says, okay, will it hurt? No, not too much. So we're going to give you some medicine that you have to swallow, so that doesn't hurt. But you have to hold still. You have to come back a couple of times, so it really takes up your day. And you need to stay away from pregnant women, from infants and children, because you're going to pee off some radioactive iodine. Yeah, try to explain that now. So now his pulse is really up, and he says, you mean when I pee, it's going to glow in the dark, so at night I can paint the wall. That'll be really cool. Well, no, that's not what I mean. What I mean is, it'll come out in your urine, and in a couple days, as long as you haven't just peed all over the house, you'll flush it down the toilet, and everything will be fine. Yes.
How long do you recommend isolation from pregnant mothers and infants?
Usually, a week is going to be easy. Usually, I think it's 48 to 72 hours.
Okay.
But I don't know.
We've heard everything from 5 to 10 to like get a hotel and have no contact.
Yeah. So that's where I would say, okay, the radiologist who's going to read this and charge for it and bill for it, they should be responsible for telling what to do. Okay? So you tell him, he goes, he gets this done, and he gets iodine 123. So why is it an iodine isotope? What?
Is what the thyroid takes up?
Because that's what the thyroid takes up, exactly. So you give him iodine 123, and it takes it up, and it demonstrates it quite well. This little thing is a marker. It's radioactive, and it sets in the sternoclavicular notch. That is helpful should this scan be abnormal, because sometimes thyroids aren't butterflies. They actually are butterflies that have a very long tail, because there may be an accessory lobe with tissue extending down into the mediastinum. Pretty rare, but that's why this is here. So it can tell you this is the sternal notch, and if you see something trickling down here, well, that's okay, that's still in the neck. But if you see tissue down in here, then now you have to worry that they have some ectopic thyroid gland that's down in the mediastinal section of the chest. Okay? So, what's the next slide? So that all, you know, you can look at that. Okay, good. So, here is an actual film. You can see these are edges of a plain X-ray film that's put in the camera that takes these pictures. So this is a normal scan, iodine 123. So this is the workup, this is the evaluation of something going on in a thyroid. Well, why would I have a normal thyroid? Why would I have a normal iodine 123 scan? Do we scan normal ones? You don't intend to, but sometimes you do. Okay, so that's okay. You know, we take out appendices in the old days that were normal, but they smell like an appendicitis, look like appendicitis, so you went to the OR and you took out the appendix. And my surgery instructor, one of Dr. Vanetta's predecessors, a former dean, Dr. G. Rainey Williams, Dr. Williams said if you don't take out some normal ones, then you've missed some abnormal ones. And so with thyroids, it's probably no big deal, but you'll eventually, you may get a normal thyroid scan. That's okay. It's just, as long as half your patients in your practice don't have it, okay? So you need to at least refine your decision-making skills. So this is normal. And these are normal, looking at you, normal with different views that project one lobe or the other better. If you look, you can kind of imagine that this is a thyroid here. Which one? This is a thyroid here with the chin and maybe the head kind of tilted up. Because there'll be a little bit of radioactive iodine in the rest of the body. It just happens to be concentrated in the thyroid. And this is that marker in the notch. So that's what you will look at, maybe, but that's what your radiologist is looking at when they give you their report. Okay? So, next question. Kind of a question before we get to the answer, really. Your patient has the iodine 123 administered. The radiologist contacts you and says that the nodule you felt on this guy is a cold nodule. So you know two things. What do you know about a cold nodule? Didn't take up the iodine exactly. And it's a nodule. It's not a cyst. Okay? She's got a cold nodule. So what's the next step for this patient? What do you tell them? That you have an increased risk of thyroid cancer in that cold nodule. You tell them everything's good. Cold nodules are fine. Don't need to see you. I should rotate this down. The finding of a cold nodule means you need to have an esophagogastroduodenoscopy, or you come back for a repeat scan in 6 months. What's your answer? 8. Okay? So, that's because if you're going to have a thyroid cancer in your patient, it's probably going to be a nodule, and it's probably going to be cold. Okay? So, We're going to take a break from these slides just a second. And we're going to have a pop quiz. I don't want to hear anybody getting sick. They're supposed to be the same. So, we're going to say, in this thyroid, you feel something this size. You feel something this size. And in this thyroid, you feel something this size. And you do this scan. You do an iodine 123. If you didn't do the ultrasound first, okay, this is kind of mixing things up a bit here. So you feel a nodule, ultrasound tech is sick, and the hospital flooded and your ultrasound machine is down. So you order an iodine 123 scan. Sorry. Which one of these, when you get this scan, remember, you felt it, you haven't been able to ultrasound it. You're only able to do this, and you get this result. How do you know which one is the cyst and which one is the nodule?
Will the cyst not uptake any?
So I have one answer that says a cyst, there'll be no uptake. Okay. What other points have you learned so far? I guess maybe I need to start over. Okay. Are you confused? Do you think you know the answer? How many of you would say you can't tell? Exactly. Okay, you can't tell because a cyst, unless it's a highly unusual cyst, cysts will not take up iodine, and cold nodules won't take up iodine. So, because you had a sick ultrasonographer and a shorted out ultrasound machine, and you did this test and got this result, you still don't know what you know. You don't know if that bump that you felt is a nodule or a cyst. You've got to fix the machine, ultrasound machine, and get your tech healthier. So then you know. Okay? So your guy comes in, he gets his study. You have to tell him, A is really the information I need to give you. You have a higher risk than the nodule over here because it's cold and because it's a nodule. Although most nodules are benign, most lumps that you feel are benign cysts or nodules, there's a small portion of them in which people have developed thyroid cancer. Most of those are nodules and not cysts, and those are almost always cold nodules. And because they're nodules, they're not cysts. Okay? So, the iodine 123 scans, I wished I could order a lot of them because I just love looking at them, but it's not appropriate. So I have to look through books and give lectures to get get my thrills out of these radioactive scans. So the next step is, we've got to figure out how to tell for sure, is this a cancer or not? So what could you do?
Fine biopsy.
So you can do an FNA, fine needle aspiration, and every cold nodule is going to do that. And generally, a good pathologist who's got skills at getting a needle in and getting a very good specimen can tell you in an hour or two, in 2 hours, whether there's something to worry about or not. If it's causing hyperthyroidism, if it's getting bigger, then you can try to suppress it. Doesn't work very well, or you can excise it. So generally, you would just excise the whole lobe and leave this lobe in. You would not go in and try to carve out. Why is that?
The nerves. If it's cancer, she might not get it all.
Okay, that's a good point. Cancer may not get it all. And risks of injuries to recurrent laryngeals or some of the nerve structures. But mainly, because this thyroid is very, 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 very vascular. And so if you're cutting a hunk out of the thyroid, it is going to bleed and bleed. And you can't keep your finger on it long enough for it to stop. And if you pack it and it bleeds and causes pressure, what happens? Squeezes the patient's airway off. So just not a good idea. So the best thing is to go and take off, cut it at the isthmus where you have less fresh tissue to deal with and lift it out in toto. Okay? So we'll say, let's go, so anything about cold nodules? Okay? Cold is bad. I hate being cold. Cold is bad. Nodules are bad. Okay? So now the other option that this nodule that you found over here in this guy, and you did a study, now it comes back with a hot nodule. It's really, really inconsiderate of the rest of the thyroid tissue, and it takes all of the iodine that's out there, if possible. And so what you get is a smattering of iodine around the rest of the gland and the head and neck. So in this example, this is supposed to be a chin and the neck sweeping onto the shoulders here, so you have an idea of where that is. So you should be able to feel this unless it's, you guys don't, unless they have a generous neck. Okay? Might be hard to feel in some of our patients anyway. So you feel the nodule, you do an ultrasound, it looks, you feel a bump. You do the ultrasound, it looks like what? This. It's solid. So you order an iodine 123 and you get this. So now you have a hot nodule. It's the example of a hot nodule. We just decided cold is bad, cold is cancer. If any nodule is going to be cancer, it's going to be a cold nodule, almost certainly. So this makes you feel better. Good news, it's a hot nodule. We can manage that. If you really, really, really want to know, I can have someone do a biopsy on it, and we can decide, does it look to be low-risk tissue for cancer? Or you could have it excised out. And most people will just say, no, leave it alone. Almost never will people have it surgically removed, okay? They may have a fine needle aspiration done to make sure it's not a cancer. That makes sense to me. I'd probably do that. And then if you decided that if this result says low risk of cancer, you've got a hot nodule, you can now do the really cool thing of burning it out with radioactivity. So again, the guy says, now will it glow in the dark when I pee in the toilet? No, it still won't glow in the dark. So you still have to be separated from your family, friends, and loved ones. And if you're really evil, you can go pee on your neighbor's shrubbery. But it probably won't have any effect on anything. So someone figured out that we can take a different isotope of iodine that we can give orally, and it can be concentrated like this iodine 123 was, and it's concentrated in this abnormal collection of cells that have produced a nodule, and it will kill them. Iodine 123 doesn't kill your thyroid. Doesn't kill the thyroid. Okay? Iodine 131 does kill thyroid tissue. So what would happen if I gave you a buttload of iodine 131 and you didn't have a nodule? It'd kill your thyroid. Okay? So probably wouldn't kill you, but you would have to take thyroid replacement the rest of your life. Okay? So that's what a hot nodule looks like, and that's the rationale for doing the 123 study, following up with the 131 study. So here's what happens. I've had 3 or 4 patients who've had a nodule that was hot, and I did the ultrasound, I did the laboratory studies, I did the 123 study. So I get down to this point where these 3 or 4 patients have this result. So, all 4 patients chose, I want you to give me iodine 131. What's supposed to happen in a perfect world?
It only kills the nodule.
It only kills the nodule. It could kill a few cells around it that are fine. That's okay. What's that called? Collateral damage. Okay. So I have these 4 patients. And because we are all professionals, we're all in school, right? Here, you're supposed to be here. I can tell you the name of patient number 4. So patient number 1 says, sign me up, I want iodine 131. Great. I make the referral, and they come back and see me. They say, perfect, everything was fine, I'm doing lovely. Thank you very much, appreciate your help. Okay, so patient number 1, they're happy. Patient number 2 does the same thing. I want iodine 131. They go to radiology department, they get their treatment, they are happy. So patient number 3, she goes over. One of them actually was a man. Usually these are women. I don't know why. They generally are. But one of them was a man, the other 3 were women. So patient number 3 goes over, they get iodine 131, they drink it, they isolate themselves, they come back a couple months later, we do their lab stuff, they're fine. Lab stuff by mean TSH. Weight's fine, vital signs are fine, no pulse, no hair loss, no diaphoresis, they're no diarrhea, they're euthyroid. So Bonita goes over. Says, sign me up, I want the same thing that these 3 people got. So Bonita goes over, she checks in, they say, you weigh so much, you're a female, you're African American, you need X, I guess, milligrams of iodine 131. So they give it to her. She comes back. She says, my hair is still falling out. I feel a little better, but my hair is falling out. And I'm still skinny. Okay? So I check her TSH. TSH is what?
Low.
Low. Like they can't even find it. Low. Okay? So I say, well, Bonita, this is not good. I don't feel anything in your neck. Ultrasound her. She has a nodule. So I call radiology and I say, what's the deal? These other three people have smiley faces. And Bonita's still hyperthyroid. TSH can't find it. She's tachycardic. She's hot all the time. She's throwing the covers off. The husband can't get comfortable in bed. He's freezing. Well, sometimes our calculations aren't quite right. Oh, really? Didn't know that. Yeah, sometimes this happens. Okay, so either you got someone who can't do math, or this is really not rare in calculating these doses. And turns out it's the latter. It's a pretty good idea. You have a pretty good idea of how much a patient's supposed to have based on their biometrics, but you never get it totally correct. But some people do. So Bonita has her first treatment, and now she's still hypothyroid, so she's sad. So she gets a second treatment, and she comes back after a second treatment, a month or so later, and she's still sad. What's the matter? Well, now I've gained 30 pounds. I don't have any energy. And I'm like, okay, well, let's check your what? TSH. Okay? So now, instead of her TSH being 0.02, it's 27.02. So I call back over to radiology and I say, well, what's up now? And I say, well, sometimes we give them too much. Okay, so how do I tell her that? Well, I said, can I send her over and you can tell her that? No. So Bonita now is permanently hypothyroid because I guess they decided, well, we will kill that nodule. And they took the rest of the thyroid that she had that was functioning. She may still have some functioning thyroid gland, but it's not enough to produce enough T3, T4 for her to stay euthyroid. So that's the name of that too, is that it can be fun and it's never perfect. Medicine never is, and so your job is to navigate that path and figure out why you didn't get the result you expected. This time. Yes, ma'am.
So for most of the time, do you, after radioactive iodine, you don't find they get hypothyroid?
Okay, busted. Actually, one or maybe two of them. I think it's rare that they get it right, where a patient doesn't need any supplement. And so the goal is that when you find this, that you're able to calculate just enough to kill the nodule and maybe a little bit of healthy tissue around it, but your thyroid is large enough and responsive enough to make up the difference. If you may have killed off a little too much the first time, your thyroid will start to produce enough. But if you killed off too much, it may not be able to. But one or two of these people were euthyroid. It worked very well. And that's, obviously, that's the goal. But generally, it's overdone. And most of the time, it would be unexpected for a patient to be on a little low-dose thyroid, synthroid, or levothyroxine for the rest of their life.
How often, when do you, how fast do you check a TSH after they have radioactive iodine?
Usually after usually 8 to 10 weeks. I usually, when I change the thyroid dose, when I bump a levothyroxine dose up or down, I give them at least 6 weeks for their TSH to kind of normalize. If you want to go 8 or 10 weeks, that's fine. But don't check it before 6 weeks. That's always what I've been taught. It takes that amount of time to get to a steady state again.
When would you expect them to stabilize out?
I would expect them to be stable in 2 or 3 months. That their symptoms will be, they'll say, I'm feeling great, and their TSH reflects that in a couple of months.
And when would you check another TSH?
If I got a normal value, let's say, remember, this is a hot nodule, so what kind of a TSH does that give you?
It's a high.
You've got lots of thyroid,
Low.
so yes, it's going to give your TSH is going to be very low, like Bonita's was, okay? And so now I forgot what the hell the question was.
So you gave them radioactive iodine, and in 2 months, you said symptoms are usually back,
Yeah.
they're still normal, and TSH has come back
So
up.
there was a hot nodule and suppressed TSH. I give them a treatment, and then I would say in 2 to 3 months, there'll be euthyroid on serum testing, and there'll be euthyroid with their symptoms. So they will feel better, they like their appearance, they like that they've not gained weight, they're not continuing to lose weight, they don't have diarrhea, they're not sweating at night, they're comfortable when everybody else is comfortable in the room. So in 2 or 3 months, the patient should pretty much be where they're going to be.
Then when would you check the next TSH?
And then, after I get this TSH, that's where I was headed, thank you for the test. So if this TSH is normal, and this is the normal range of the TSH, okay? And here, you gave them iodine 131 at this point in time, when their TSH is really low. So then, now you're out, say, 2 months, the TSH is normal, and their symptoms are normal. I would check it again in 2 more months, at least 6 weeks. So I'll say 4 months out. Why do I want to do that? Why do I want to do a second one?
It's because there's reserves in the thyroid.
I didn't hear it.
There's reserves within the thyroid. that
Okay.
make up the deficit.
There's a little bit of that, but you want to make sure that it's not actually on its way out because they didn't get enough, like Bonita didn't get the first time, okay? Or, I'm sorry, that you overkilled it, sorry. So that if their TSH is going really high, it's because you killed too much of the thyroid. So you want to do a second one to make sure that it's just floating along in the normal range.
So your experience is most of the time you can knock out the nodule and leave enough healthy tissue to keep doing it. Okay, that's,
Yes.
okay.
That is the goal. Everybody agrees with that. That's what the intent is, but it's hard to do in practice. Excellent. Okay? All right, so anything else? Any more questions? We'll go to the parathyroids. All right. Parathyroids never give you trouble unless they're overactive. There's no hypoparathyroidism, really. guess you should think about it, but it's not going to happen. Why? How many do you have? 4. Yeah, so surely one of these guys is going to be normal, okay? So it's just rare that they underfunction, that you have hypoparathyroidism. So invariably, parathyroid disease is a disease. If you told me someone had a parathyroid disease, I would assume they had too much parathyroid hormone. So if that's not what you meant, then you need to tell me. Symptoms are caused because of what happens when the parathyroid hormone goes up. You know it stimulates calcium resorption from bones, so patients say they hurt to my bones. My bones ache. Yeah, I know, but you're also on Zoloft. Take, X, Y, and Z, and I just think you're just plain nuts. No, these patients are not, and so they really do hurt in their bones. And because their calcium is high, they may have weakness. This second red bullet, the weakness, anorexia, weight loss, fatigue, confusion, you know what that other thing that looks like Neptune's Triton is? That's my shorthand for psychiatric, okay? That's what that means, confusion or psychiatric, frank psychosis. Treatment, if you, we'll jump ahead a bit here, if you find a parathyroid adenoma, treatment is generally surgical. If they are this symptomatic, okay, for the long run. Acutely, you have to do something else to treat all of this, but the treatment, definitive treatment, is surgical excision. How many men over 90 will have prostate cancer? All of us, okay? Welcome. Similarly, many patients, if you live long enough, will have a parathyroid adenoma of some sort. Okay? The nice thing is that they may have a hyper-functioning adenoma, but it's just kind of a hiker. They really don't overfunction too much. And we only know they have them because we go and look for them with what test? A PTH. Okay? So do I just order a PTH on people? No. It's expensive. So why would I order a PTH? Are the people that I think have a parathyroidoma weak, anorectic, and actually, frankly, psychotic? No. What do we order on new patients? Annual exam, wellness, physical. A what? CMP, a complete metabolic profile. And what you find is phosphorus is not on a complete metabolic profile, but a calcium is. So, calcium comes back high. And so normal is, I don't know, we'll say 8 to 10.5. And so the calcium comes back 10.9. The patient is fine. The patient has no symptoms. Okay? They're not taking handfuls of calcium every day and vitamin D. They're not eating 2 pounds of cheese and cottage cheese every day and in the sun. Okay? So it's not that. They're fine. They're normal. And they can have this 10.9 till, as my grandfather would say, till hell freezes over. It won't make any difference in their longevity or in their morbidity or morbidity. They'll be fine. But we find it from time to time, and so we feel obliged to chase it. So what's the first rule of getting an abnormal lab value?
Does it match the patient's presentation?
Okay, I would think about, I get the lab value and I think, well, did they really look X, Y, or Z because this lab is abnormal? That's good, but
Check them again.
what?
Do it again. Like check them again.
Do it again. Repeat it. So if their calcium comes back 10.9, so I cross my fingers, I order it again, and now it's 11.0. So now what do I do? Here's what I used to do. I'd say, okay, PTH, do a parathyroid hormone. And I still do that. Okay? So I still then order a PTH because I feel like I've got to find that one parathyroid hormone that I've yet to find, or at least number 2. So we'll say parathyroid hormone is normal is 10 to 25. It's somewhere around there. Okay? So I get this. My patient's parathyroid hormone is 31. So what I used to do, I would ultrasound these people, spend $500. I'd send them to the endocrinologist, spend $600. They come back to see me, $1,100 poorer, with a note that says, check this lab. When? When? Once a year. I thought, well, it's abnormal. It's not normal. And this is not normal, so shouldn't we do something? No, Jim. You should not do anything. Leave them alone. And so I've become more comfortable determining that my patients have a parathyroid adenoma. Who gives a flip? It's okay, you have it. We'll pay attention, and it'll be on your problem list, and your health insurance company will know it, and I'm going to check your calcium once or twice a year. And if your parathyroid hormone in July of 2018 was 31, maybe I'll do it in December of 18, and now it's 32, and I say, fine, I'll wait until Christmas of 2019, and it'll be 35, okay? And so, and their calcium is now 10.8 next year. So you don't really worry about it. Interesting to know about, vacinoma, but of long-term, no consequence, okay? But you at least need to acknowledge that their calcium is abnormal, repeat it, still abnormal, then I do a PTH, and if that's really elevated, like 200, I'll do an ultrasound. And then I send them to endocrinology as well. Because they may have a parathyroidoma, well, they do have a parathyroidoma, that may, over time, at this level, cause calcium to continue to increase to higher levels. These patients, your mother's probably 11.0. Is she crazy? No. But when her calcium gets to be 17, she'll be crazy. This I have seen. And those patients are as if they are having a full-blown schizophrenic attack. They are very difficult to manage. And so yes, this may be a psychotic episode, but you need to be sure that it's not because of the parathyroidoma, because you can fix that. What's the comment? You can't fix crazy. Okay? So if you find that her PTH is 250 and her calcium is 16, those are sick people. They need to be medically managed before psychiatry is even going to walk in the room to see them. And so once you then get their calcium down, their mental status improves, and then you can make a decision whether they truly have a psychiatric illness or not. Because if they If it's strictly a parathyroid adenoma, it will go away when that medical condition is resolved. I have, as I said, I've seen this one time as an intern, and it's frightened me because she was a big woman, and I knew she would squash me. And at the VA, at a time when women just never had beds at the VA. And so it's one of those incidents you will never forget. You will have these during your professional career that make you chuckle. And you think, how did I survive that, or what was I thinking when I ordered that test or did that procedure? But back to the topic at hand. So what you'll find a lot of is modestly elevated calciums that persist, that may prompt you to do a parathyroid hormone, that may be up. And my endocrinologists have taught me that if it's 30 or 40 or 50 on their PTH and they're asymptomatic, they're not having bone pain, they're not having symptomatic hypophosphatemia or hypercalcemia, then you just manage them medically. You may want to do an ultrasound initially to figure out if you can see something going on in the parathyroids. Generally, there will just be one of them that's the culprit, but there may be others. And where thyroid adenomas, cold nodules, where cold thyroid nodules may be cancer, have the highest risk of being cancer, you rarely, you would be hard-pressed to find a case report of a parathyroid malignancy. They just are rare. The more common thing that you find incidentally is when your calcium is up and you find your PTH is up. If I draw this, if this is a little up and I repeat it and it's a little up, I draw this, but I also check up a phosphorus, a phosphate, okay? But what you're more likely to find, rather than a malignancy, you're more likely to find this condition that still is uncommon, called multiple endocrine neoplasia. It comes in a variety of forms, 1 and 2, and these are familial conditions with frequent malignancies. So I don't keep these conditions straight. I can't tell you the difference between MEN1 and MEN2. I don't know which is more likely to cause you to die as a result of the condition or not, but there are familial, there are cancers associated, such as pancreatic cancer, thyroid cancer. So that's the reason you should continue to evaluate a mildly elevated calcium. And then how are you going to figure this out? What do you want to do? I heard of genetics. You could, but that's expensive and you really need to know for sure that it's necessary.
Can I get HBI? Isn't there already?
Say that again?
A good HBI, isn't there?
You have to talk to patients, exactly. You need to get a family history. So you have to ask them, anybody have cancers in the family? Just throw out the word cancer, and they'll tell you someone had a skin cancer, or grandpa had a lung cancer and he smoked a lot. But if you hear pancreatic cancer, stomach cancer, colon cancer, liver, any of the GI tract cancers, then you want to delve a little bit more to prove that the patient who has calcium that's up, PTH that's up, and cancer, GI cancers in the family, to make sure that they don't have, that your patient doesn't have that, so that you can then help them decide if other members of their family, brothers, sisters, or their children need to be evaluated for MEN1 or 2. So we're going to ultrasound, and you occasionally may find something, but again, it's fast, it's quick, it's cheap, and it doesn't hurt. Then the next thing that's done, if you decide that this is a symptomatic enough parathyroid adenoma that it needs to come out, then you do some really unusual scans. So probably, unless you're a PA working in radiology or a PA working in an endocrinology practice, you probably never will see these or hear about these again. But they're another isotope of one of the elements which someone has figured out is desirable by the parathyroid glands. And so this patient probably has 2 overactive parathyroid glands. So you can see that whereas in an iodine scan, you don't have much scatter across the rest of the body, in a sestamibi scan, it's still taken up by the normal tissues of the body, but it does become concentrated in the parathyroid adenomas. And that then as the radiologists, or actually the CT techs, do their magic and change the windows and stuff, they can get it to concentrate and give you a better idea where it is in the body. But this would be kind of the initial scan of that. In the old days, you would have a patient who said, okay, everybody agreed you need to have the parathyroids out. And so you went to medical school, so you're the first assist PA, and the surgeon pimps you and says, so how many of these, or how many specimen buckets do we need when we do this surgery? And you're going to say 3. And he'll say, why 3? And you say, well, you're going to keep one, right? Okay? So you don't throw them all away. But in the old days, last century, you would kind of go in, explore the neck, which in and of itself was dangerous, and you'd find the floor, and you'd kind of feel around and say, well, that one feels kind of soft and mushy. That's kind of normal. Oh, this one feels firmer than this one. And so you'd say, okay, that one goes in a bucket. And you'd kind of circulate through all 4 of them and figure out which one you could gamble and say, I'm only taking out the one that feels the most abnormal, and close the neck and go back, and hopefully you've got the right one. But you run the risk of still having an abnormal adenoma still left in the neck. So then they decided, well, now let's take 3 of them out, and the one that seems to feel and look to be the most normal, we'll put under the sternocleidomastoid or in the forearm, because 1, it'll just magically grow and live there. You don't have to transfer it with a vessels attached. It will take up residence and start producing parathyroid hormone. And if you were lucky, you put a normal parathyroid gland sub-Q, and their calcium was normal, their parathyroid hormone was normal, and their craziness went away. But if you were unlucky, then you knew that you had to go back, and it was now easier to access. You didn't have to run the risk of damage to structures in the nerve. So that's what that transfer was about for several decades. Nowadays, what is able to happen is parathyroid hormone is really easy to test for, and labs are set up for this. So you do this study, you figure out these 2 are the ones that need to go in the bucket. So you find them, take them out, send them to pathology while they're looking at them for the next 30 minutes and say, yep, that looks like an adenoma, or no, that's normal tissue. You can draw PTH, and in 30 minutes, the patient's still under anesthesia. The anesthesiologist is still checking off every 15 minutes, ka-ching, ka-ching. So that you send a serum sample down for parathyroid hormone, and they can run the value. So now, instead of being 200, now it comes back 25. Literally within the hour of the first incision. So now you've done this scan, you've taken out the 2 suspects, and you've done an intraoperative PTH, and they have a normal value. If the PTH comes back at 185, now Now you have a decision to make. I got 2 left, which one is it? And so you may take one out, throw it in the bucket, so you've used all 3 buckets now, and you transplant the other one more superficially so you can access it. But this is what the scan looks like, and the intraoperative PTH is kind of a nice development over the last decade or so.
Would there be any merit to doing a second intraoperative PTH?
Oh, yes. I see what you're saying.
Like you're down to 2.
Yeah. Because
Just rinse and
what
repeat?
if it was here, and you took out, you decided to take out 3, and now what it actually, so an hour and a half later, it's now 2. Well, you get a bucket back. Maybe you need to stick one of those back into the patient. But that would tell you then that the 4th one that's left is not functioning. Okay, so that would be a little unusual, but it might not be functioning. I mean, it should be functioning because your PTH is high. And well, actually, no, that's not right. It wouldn't. It may not be functioning very much because the parathyroid stimulating hormone has been suppressed by this adenoma, and so if it's low, I suppose we run the risk of having left one that doesn't work, but probably that's just a result of being suppressed for so long. It should come back.
Okay.
Okay? And so another option are thallium scans, and you can see this one, the two darker spots on the left-hand screen. These 2 are parathyroids actually showing up again. Protectinate is another isotope that you could use. It will outline the thyroid gland as well as some parathyroids, and it may show some exogenous thyroid or parathyroid tissue down in the chest. So these are ways we can image. Generally, I just reviewed this a couple of days ago. It's still generally the thallium and the sestamibi scans. And so this is a normal study. You can see in the upper left, you can see the patient and their head tilted back. You can see the parathyroids, and you can see some GI organs. You can see a liver over here. You can see a little bit of dye still left in the stomach wall, and that's at 15 minutes. Then the next one in the bottom right left corner is 2 hours later. So you can see that it's pretty much cleared out. These 2 areas that are highlighted in 15 minutes, there's no area that seems more dense or brighter on this scan at 2 hours or so. It's still there, but it's pretty, it's benign in its appearance. As opposed to this one, in which you can clearly see at 15 minutes and again at 2 hours, there's a nodule that remains active, hyperactive. It's taken up most of the radioactive agent, and it's still hanging on to it at 2 hours. And so the other glands that have kind of shown up here have cleared away, and the overactive adenoma, or the adenoma, is still there at 2 hours later. So these are, again, traditional X-ray films in which they have a special camera that is able to capture this radioactivity. Okay, that's it on parathyroids, okay? Adrenals are next. Adrenals, can give you lots of problems. There's, I think, a whole slide dedicated to high and low functioning adrenal glands. If you think your patient has a condition related to their adrenals, the most common is probably an elevated glucose, and maybe sometimes there'll be, in some patients there'll be low potassium, and then there may be symptomatic patients in which you're thinking of pheochromocytoma. Generally, if an adrenal gland tumor is what is rolling around in your head after your exam and history and initial screening lab, then generally the ultrasound is going to be the next step again. For the same reasons, inexpensive, easy access, doesn't hurt. And it does very well at outlining these areas, kind of this area. It doesn't, adrenals are evaluated with a posterior ultrasound technique. You can't get them if you run the ultrasound probe from the top down. It has a limit, ultrasound has a limit to how deep it can go and how much fat it can penetrate, but it will, with a good technician, will demonstrate quite well. If there's an abnormality there, it will demonstrate whether that's coming from the adrenal or whether it's coming from the kidney that's giving you your either your symptoms or your electrolyte abnormalities. So this is a normal scan. Okay. So your longtime patient is concerned about fatigue. It's been increasing over the past 2 months. Your exam is notable for a pulse of 108, weight gain of 17 pounds, stria over the abdomen, scattered bruising, and a random fast, that shouldn't be FSB, but a random sugar of 157. Your laboratory testing suggests Cushing's disease. Which of the following is indicated to be obtained first? So what did I tell you? Ultrasound, okay? So ultrasound is good, can tell you, yep, there's something there, but then it won't tell you what it is. You have to then follow up with either a CT or an MRI. CTs are generally cheaper and easier to get than MRIs. CTs are less problematic for the patients because they don't require quite as long a time in the tube on a hard surface. The ultrasound is good at showing you retroperitoneal structures, as does the MRI. But even if you're absolutely sure this is an adrenal tumor that needs to come out based on an ultrasound, symptoms, and laboratory testing, your surgeon's going to want an MRI. So you're still going to get it, but it's not the first thing. CT is good when your tumors are 2 centimeters or more. MRIs are good for 1 centimeter or larger. That tends to be what the cut points are. And remember that adrenal tumors may be bilateral. Not very common, but they can. So just because that's the problem for radiologists to address, though. That's not your problem. But the radiologist shouldn't get so excited and focused on a right adrenal mass that they miss a subtle left adrenal mass as well. So when you're reading through the results of that MRI, you need to be sure that they address that both left and right kidneys are fine and both left and right adrenals are fine. You've had, you know that steroids really come as kind of 2 general types. There are glucocorticoids like cortisone that mainly affect glucose. And there are mineralocorticoids like aldosterone that affect the minerals, which are actually what? Sodium and potassium. They're really metals, right? So the mineralocorticoids and the glucocorticoids. And the outer zone on adrenal glands is where the aldosterone is produced. The inner region is where you get the cortisol production, and that's probably the most common abnormality of an adrenal gland. Cancers are never the most common abnormality of any of these glands. Benign adenomas are the most common abnormality. And so the most common adrenal abnormality is going to be, most likely is going to be Cushing's syndrome, where you have overproduction of cortisone and that, or cortisol, and that causes an elevation in your sugars, and increases your risk for diabetes. That is why your asthmatics who are diabetics, who have frequent crises, may never have a good A1C because you're unable to get their asthma under control because they're using exogenous steroids. Ideally now, medicine, our inhaled corticosteroids are less likely to do that. But in the old days, we would see a lot of asthmatics who had round face, round bodies, overweight, and diabetics because their lungs were so bad that we used so much steroids, they became diabetic and they looked like a Cushing's patient. So, just like finding an abnormal or having hyperthyroidism in a patient, if you have cortisol that's overproduced by the inner layer of the adrenals, you need to decide, is that really an adenoma going on in the adrenals, or is that a pituitary thing again? So this is where you get back to getting back to your pathophysiology. Their sugars are up high now, and they've got some stria. They have centripetal obesity with spindly arms and legs. So maybe this is not just diabetes, which we have in the United States. Maybe this is really from a cortisol-producing tumor that's primary in the adrenal, or maybe this is a pituitary adenoma producing too much ACTH, which makes the adrenals produce more cortisol, which then gives you these same physical and laboratory findings. So just because the traditional Cushing patient walks into your room, into your office, who has central obesity, thin limbs, stria on their abdomen, prominence of a dorsal fat pad, doesn't mean they're necessarily Cushing's from an adenoma. They may have a pituitary adenoma. If you take a good history and they say, well, yes, my vision's gotten bad because I seem to sometimes see double. That's, show me the money. That's what I would be doing an ACTH on that patient, and I'd be looking at their head, not ultrasounding their adrenals. So you need to work your way through all of these pieces will fit together when you have it right. If you can't make a piece fit, if you can't explain it, then you need to start over and figure out where you probably went wrong and change it or get more information. Sometimes that's historical, sometimes that's laboratory, sometimes that's imaging. But then it can help you, if you get a good history and do a good exam and order the right serum testing, you'll know how to target your imaging studies. Okay, PHEOs, usually they're big enough to show up on a CT when they become symptomatic. So they're generally going to be 2 centimeters or more. The Where that may not be true are adolescents, rare, or thin individuals. You know, the runway model type of people where they have less lean body mass or less body mass to be responsive to a modest increase in adrenal epinephrine. And so most of the time, most Americans, when they present with a FEO, will have one that's large enough to show up on a CT. An ultrasound is okay to do, but if you think it's a FEO, there is now special, you need to tell the radiologist you want CT imaging looking for a FEO. They will do a specific dye injection, and they will do CT slices in a certain timed sequence. Rather than injecting you and doing the CT, they will do it based on a time regimen that has been studied and determined to be the FEO protocol. And so that's getting more and more common nowadays, that CT and MRI studies, if you need to tell your radiologist what you're looking for if you're doing a contrast study, so they know that you've got the right agent and that they do the timing properly so that you're more likely to cause that tumor to flush. Because if you do it too soon or too late, you miss that window where that tumor is really bright on a CT or an MRI scan. This is a rather remarkable study. This is the adrenal, this is the FEO tumor. They can be rather large, and you wonder how patients can manage to tolerate an adrenal tumor that gets to be that big. One of the reasons is nobody pays attention to them. And so you think, no, it can't be a FEO, or no, you have hyperthyroidism. That's what it is. It's just your thyroid. I need to adjust your medicine because they do have hypothyroidism. They're on thyroid supplements, and so you just say, well, I'm giving you too much. I need to cut back. And so you've gone another 2 months or 6 months before you finally think, oh, well, maybe I need to look at their TSH, or maybe I need to look at their adrenals because FEO symptoms and hyperthyroidism symptoms have a lot of commonality. If there is a large outpouring of adrenaline from these tumors, patients may actually become psychotic or have more psychiatric symptoms. They have tremendous anxiety, they're sweating, they're nervous, they're jittery, they can't sit still. And so at that point in time, you have this question of whether this is actually a psychiatric illness manifesting itself. Because most of us would think that rather than thinking about a FEO. And so you help rule it out by making sure that they don't have hyperthyroidism, or they don't have thyroid disease, that's causing some of these symptoms. And if those studies are normal, then you need to be looking for that potentially they have a pheochromocytoma. And it involves laboratory testing, serum testing, urine testing, but it also involves CT, at least a CT. Don't worry about ultrasounds, and probably if there's something found on a CT, then the recommendation from endocrinology and from the surgeons are going to be an MRI. And adrenal tumors can actually metastasize, but these involve figuring out whether they have by using another special study that I suspect none of us will ever see, short of maybe PAs who work in an endocrinology setting. And This is a good example of how technology can show you that you can design substances that have an affinity for a given tumor. And so you are on the edge of that genetics aspect and cell, DNA management, and you see advertisements for lung cancer where if they have the biopsy, they can design a drug to target specifically your lung cancer cells. And so I suspect we'll see more and more of that may become less toxic, easier to manage, and not just in tertiary care centers, but out in places like Ada or Ardmore or even Poto. So these last couple of studies are ones you probably won't see very much. Really, again, it's going to be pituitary tumors, thyroid tumors, and maybe parathyroids that you will be managing, at least in primary care, during the course of your career. And these others are ones to keep you on your toes. And so remember, all of us find a lot of people who turn out not to have pheochromocytomas. Okay, so that's it. Questions? If you do, send them to me or to Dr. Latassi. She can send them on, and I'll get a reply back to you. Or you can give me a call at